In this video, I will go over different plasma cell disorders. So in general, B cells differentiate into plasma cells which will produce immunoglobulins. And multiple myeloma is a cancer of the plasma cells that can produce IgG or sometimes IgA immunoglobulins. Now, given that these immunoglobulins are coming from a single origin, therefore these are monoclonal. Versus if someone has an infection and then there is increased production of immunoglobulins which is coming from different origins of plasma cells, then that would be considered polyclonal. But since this is a cancer and they're all proliferating from a single cell, this is a monoclonal proliferation of the immunoglobulins. Now, if you run a serum electrophoresis, you will get different proteins and the gel, which corresponds to albumin, alpha chain, beta chain, and gamma chain. And this gamma chain goes for the light chain of the immunoglobulins. So in patients that have multiple myeloma, there would be a monoclonal spike of the gamma chain, and this is referred to as M spike. So the mnemonic that you can use to memorize the features of multiple myeloma include the CRAB. So C goes for hypercalcemia. So since there is monoclonal protein that is binding to the calcium in the serum, these patients have hypercalcemia. In addition, they will have renal failure. So hypercalcemia is a factor that contributes to renal failure itself. In addition, since there are so many immunoglobulins, their light chains will form the Bence-Jones protein casts, which will damage the kidney and cause renal failure. In addition, these patients present with anemia and leukopenia. So the fact that these plasma cells are proliferating inside the bone marrow, there is not much space for the other cells to grow, and thus there would be anemia as well as leukopenia. And thus these patients present with recurrent infections, which is the most common cause of death in patients with multiple myeloma. And finally, due to the proliferation of the plasma cells in the bone marrow as well as osteolytic bone lesions, these patients will present with bone pain and may sometimes develop pathologic fractures. So here would be an image of a patient with osteolytic bone lesions. In addition, their plasma cells will have some immunoglobulins that is proliferating in the cytoplasm, so they would have a fried egg appearance. And then one other feature that is characteristic of multiple myeloma is Roulette's formation of the red blood cells, which resembles a stack of poker chips that are on top of each other. The next disorder is Waldenström macroglobulinemia, and in this disorder, there is an IgM proliferation. So this is also a cancer of plasma cells, but there is an IgM proliferation. And if you recall, IgG presents as a monomer, IgA presents as a dimer, but IgM presents as a pentamer. So because of the same reason, since these patients have hyper IgM, there is a monoclonal spike of the IgM in these patients, so there would be an M spike of IgM. Therefore, since the IgM is highly viscous, these patients will develop hyperviscosity syndrome, and thus they can present with priapism, blindness, cold agglutination, or Raynaud syndrome. One feature that does not exist in Waldenström syndrome is the bone lesions. So if on the exam you see a patient that has M spike on serum electrophoresis as well as bone lesions, it is not Waldenström syndrome. It has to be multiple myeloma. So keep that in mind. Bone lesions do not present in Waldenström syndrome. The final disorder is monoclonal gammopathy of undetermined significance, or MGUS. And this disorder can present with the production of either IgA or IgG or IgM, which can progress into the Waldenström macroglobulinemia or multiple myeloma in the other form. So in other words, MGUS is a pre-malignant forms of these disorders, but it is asymptomatic. And that concludes our discussion.